So today I'm going to give you a basic primer of space infections. Space infection होता क्या है, कैसे spread होता है, and then after you guys come back from your vacations, I'll be talking about every space in detail in the next 1 or 2 lectures. Before we talk about space infection, we need to understand what a fascia is. So a fascia, by definition, it is a thin layer of connective tissue, fibrous tissue that surrounds and supports every part of the body, be it muscle, be it vital structures like heart, liver, lungs, organs, nerves, bones. Un sab ke around we have the fascia. And I'm sure you have heard of parotid capsule. Even that is a part of a fascia. Investing layer of the deep cervical fascia divides into two, deep lamina and superficial lamina, and it engulfs the parotid gland. And that is what is called as parotid capsule. So I'll show you what a fascia is. Can you see this shiny layer overlying the muscle? So there are two muscles here and both are separated by this fibrous shiny layer. This is a fascia. Then we come to something called as fascial spaces. Now fascial space is basically it is a potential space. Abhi space hai nahi. In a normal human body there is no space between the two facial planes. Though two fascias ke beech mein there is no space. It is filled by a very thin layer of connective tissue. But when we apply pressure in that region and when we necrose the loose connective tissue and we push apart the two layers, then we get a space. So basically this is the definition, a potential space between the two fascia, normally filled with loose connective tissue bounded by anatomical barriers, that is bone, muscle and facial layers. Now, the word to remember here is potential space. Jo maine bataya, in a normal individual, in a normal human body, there is no space there. But under certain circumstances, this space can be created. So there is a potential for a space to be created in that region. That is why it is called as potential space. Space hai nahi, but it has the potential to create a space. We'll take an example of a balloon. Currently this balloon is deflated. There's no air or anything in between the two walls of the balloon. So the balloon walls, they are sticking to each other. Currently there is no space between the two walls, right? But as soon as we push water into this or air into this, there's a space created and now we have a space. So we can say there's a potential space between the two walls of the balloon. Once enough force is applied, space will be created. So that is called as potential space. Any infection, head and neck infection, space infection, it will show up clinically as either cellulitis or abscess. Now cellulitis may you rarely see pus. It is mostly by the spread, the causative microorganism is streptococci and they usually cause production of gaseous production rehta hai. So because of inflammation and gaseous production, the two layers, they are pushed apart from each other, the facial layers, the fascia. So we have a space created there and wahan pe either we have the gaseous content or agar abscess hai, to pus content wahan pe rahega. Now, because of this pressure, I've already talked about this in the last lecture. Because of the pressure from this gaseous content or the pus, there is increased pressure at the site of the infection, right? Because of the increased pressure, there is occlusion of the terminal capillaries, the arteries. Because of this occlusion of the arteries, there is reduced blood supply to the site of infection. Because of the reduced blood supply, there is reduced supply of the antibiotic at the site. So, what can cause the cellulitis or an abscess? Basically, what can cause a space infection? These are all the cases: periapical abscess, trauma, periodontal abscess, periimplantitis, malignancies, or if you nowadays this is one of the least causative factor because nowadays we use a disposable syringe. So I'm going to talk about this in detail. That is the periapical abscess secondary to the dental caries. So what is the sequence of events? First, there is dental caries. If we don't treat it, it is going to lead to infection of the pulp and leading to pulp necrosis. Pulp necrosis hoga, then it will lead to periapical abscess. After periapical abscess, we're going to see the abscess is going to spread, grow inside the bone. Now, bone is made up of two things, organic and inorganic structure, right? So inorganic structure, that is the minerals, they are going to be resolved by the acidic pH of the abscess. One. Second, जो organic content है, that will be resolved by the streptokinase or high hyaluronic acid produced by the microorganism. So ये दो चीजें resolve होती जाती हैं as the abscess expands, and as soon as it reaches one of the wall, be it palatal, be it buccal, whatever wall, and depending on the proximity to the space, it is going to lead to space infection. This is the tooth with the periapical abscess. Now this abscess is going to expand in all directions equally, right? So it is going to expand in all directions equally in a circular manner, spherical manner. If we allow it to further expand, it is going to reach one side जहाँ पे bone कम होगी and it is going to perforate the cortex on that side. So for example, in this region, molar, there is a caries, pulp necrosis हुआ, उसके बाद periapical abscess हो गया. Now this periapical abscess is on the buccal root of the maxillary molar. Now as this abscess expands, it is going to reach the buccal cortex first. It is going to perforate the buccal cortex and it is going to drain onto the buccal side of the bone. Similarly, if there is abscess on the palatal side of the root, then you're going to see palatal abscess because the abscess is going to breach the palatal cortex first. And in cases where the sinus is closed, it might drain into the maxillary sinus, leading to odontogenic maxillary sinusitis. So depending on the thickness of the bone and depending on the proximity of the root to the cortex, it is decided which space or which area is getting infected. Now we come to anatomy. Before we talk about the space infections in general, we have to talk about a few things about anatomy, especially the muscles. So what is this muscle? Buccinator muscle, okay? So basically, origin of this buccinator muscle is from the alveolar bone of the maxilla and the mandible, one, and posteriorly the origin is from the pterygomandibular raphe. Okay? And the insertion is at the orbicularis oris muscle. The roots of the posterior teeth, premolars and molars, it is almost at the level of the insertion of the buccinator muscle, be it maxillary teeth or be it mandibular teeth. The attachment is at the level of the apex of the maxillary and mandibular teeth. Remember this, ye kaam aayega. Now depending on the level of the attachment, either if the root apex of the upper or lower teeth, in case of upper, if the root apex is below the attachment of the buccinator muscle, we are going to see the involvement of vestibular space. If the root apex is above the attachment of the muscle, buccinator muscle, we are going to see the buccal space. This is the buccal space basically. The space between the buccinator muscle and the superficial, the skin, in दोनों के बीच में we have only subcutaneous tissue, loose connective tissue है. And it is very easy to necrose it and spread the two structures. This is an example of the buccal space infection. Similarly, in case of mandible, mandibular posteriors, if the apex is above the level of the attachment of the buccinator muscle, we are going to see the vestibular abscess. If the muscle attachment is above or the apex is below the attachment of the muscle, we are going to see the buccal space infection. Easy enough? Now, what is this muscle? Mylohyoid muscle. So the origin of this muscle is a mylohyoid ridge or mylohyoid line of the medial surface of the mandible, and insertion is at the superior border of the body of the hyoid bone. So again, the same thing, the attachment of this muscle is at the level of the apices of the mandibular teeth, especially the molars. Aage jate jate the attachment goes to an inferior position. So these anterior teeth, they have apices mostly above the attachment of this muscle. So mostly the relevance of this mylohyoid muscle in space infection is in cases of posterior teeth, premolars and molars. So you can see the molars and the premolars, the attachment of the mylohyoid muscle, that is the mylohyoid line or mylohyoid ridge, it is at the level of the apices. And this mylohyoid muscle, it divides the floor of the mouth in two spaces, potential spaces. So this is the mylohyoid muscle. So it divides the floor of the mouth in two. That is, the superior one is the space between the mylohyoid muscle and the oral mucosa, floor of the mouth, is the sublingual space. This is the space that is sublingual space. Whereas the space between mylohyoid muscle and the superficial layer of the deep cervical fascia, this is the submandibular space. We're going to go into details of all the contents and the layers in every space in the next lecture. Basically, the mylohyoid muscle divides the floor of the mouth into two, that is sublingual and submandibular. What is this muscle? Mentalis. So now mentalis muscles, they have origin from the alveolar bone in the labial cortex of the alveolar bone in lateral and canine region, mandibular lateral and canine region, and the insertion is in the skin in the chin region. So this is the mentalis muscle. Now, if you see, there is a thin space between the two. So, if there is a periapical abscess in the lateral incisor or canine region, and if it expands circularly, of course, spherically, abscess expand ho raha hai. If it reaches the lingual cortex, it is going to cause sublingual abscess. If it reaches the labial cortex first, either depending on the attachment of this muscle, it is going to cause vestibular abscess or submental space infection. I'm going to show you the pictures. What is this muscle? And this is a difficult one. It is levator labii superioris. So the origin of this muscle is from the infraorbital rim, medial aspect of the infraorbital rim, and it inserts into the lip region, not the bone. It inserts into the soft tissue, that is the lip, that is the vermilion border. Now, as this is inserting into the lip region, not the bone, and origin is from the infraorbital rim. So there is a triangular space, lip and the bone. There is a triangular space, let me show you. So this is the insertion in the lip region, soft tissue. Origin is in the infraorbital rim, and this is the bone. So there's a triangular space that is called as canine space infection. Now, इसमें it doesn't matter कि कौन से level पे muscle attachment है, because it is not inserting in the bone at the level of apices, right? So अगर canine से या premolar से infection spread हो रहा है in the labial cortex, it is directly going to go into the canine space infection. समझ आया? In case of buccal mylohyoid, it was dependent on the attachment of the muscle. Okay, but यहाँ पे the attachment, the insertion is not in the bone. It is in the soft tissue. So we have already the space that is involving the apices. So let us talk about the different teeth. कौन से teeth से कौन सी space infection होगी? So first maxillary posterior teeth. आपको क्या लग रहा है? कौन सी muscle attached होती हैं maxillary posterior teeth में? Which is relevant to space infection? Only buccinator. Okay. So we're going to talk about buccinator muscle. As I talked about earlier, depending on the root involved and depending on the thickness of the bone, we're going to see different spread of infection. In cases of buccal root that has a periapical abscess, this abscess is going to spread to the buccal aspect. If the periapical abscess is at the palatal root, we're going to see the spread of the abscess into the palatal, it is going to breach the palatal cortex and go into the palate. That is called as palatal abscess. And if it spreads to the maxillary sinus, it is maxillary sinusitis, odontogenic origin. Now, we've already talked about the attachment of the buccinator muscle. It is at the level of the apex of the upper and lower posterior teeth. So, depending on the attachment, if the attachment of the muscle is above the level of apices, it is going to, the abscess is going to drain into the vestibule. So, that is vestibular abscess. If the attachment of the muscle is below the apex of the molar teeth, posterior teeth, then it is going to, the abscess is going to spread to the buccal space. Okay, so that is buccal space infection. And this is how a buccal space infection looks like. You can clearly see the swelling in the cheek region of the patient. Now, there's a small difference. यहाँ पे we are talking that either it can be palatal abscess, either it can be a vestibular abscess, or it can be a buccal space infection. In case of maxillary third molar, there is a exception, because if the roots of the maxillary third molars are closer to the posterior wall of the maxilla, this abscess can go easily to the infratemporal space also. So from the maxillary posterior teeth, either it can be palatal abscess, either it can be vestibular abscess, buccal space infection, or infratemporal space infection. Then we come to the maxillary anterior teeth, especially lateral canine. We have the levator labii superioris muscle. Again, the insertion is at the lip region, in the lip, vermilion border, and origin is from the infraorbital rim. So if there is a breach of labial cortex because of the periapical abscess in the anterior teeth, it is directly going to go into the canine space. And this is how you see a canine space. Clear swelling and inflammation in the infraorbital region and the cheek region. Now, if we are talking about the space infections of the head and neck region, we have to talk about danger zone of the face or danger triangle of the face. Again, I'm going to talk about this in detail. Abhi bas ek introduction. So this is the danger area of the space. The reason for this is basically if there is an infection in this region, upper lip and the nasal region, the infection from this region can reach the brain and lead to cavernous sinus thrombosis also. There are no walls in the veins in the head and neck region. So the infection here can flow in the retrograde direction, can reach the brain and lead to meningitis, cavernous sinus thrombosis, and this is going to be fatal for the patient. It can lead to death of the patient. So you need to know about this thing. Now we come to the posterior teeth. Two muscles that are relevant to space infection in case of mandibular posterior teeth. That is buccinata and mylohyoid. Same as was the case with the maxillary posterior teeth, same is with the mandibular teeth, mandibular posterior teeth. If the attachment of the buccinata muscle is below the level, apical to the level of the apex of the mandibular posterior teeth, the spread is going to go into the vestibule, that is the vestibular abscess. If this attachment is above the apex of the mandibular posterior teeth, the abscess is going to spread into the buccal space, leading to buccal space infection. This is in case where the abscess goes to the buccal side. Now, if this abscess spreads, if this abscess reaches the lingual cortex first, then depending on the level of the attachment of the mylohyoid muscle, if this mylohyoid muscle attachment is above or coronal to the apex of the posterior teeth, you're going to see the submandibular space infection. And if the muscle attachment is below the level of the apex, you're going to see the sublingual space infection. So basically the attachment of the muscle is going to govern which space is getting involved. And this is how a sublingual space infection looks like clinically. Because of the muscle attachment, if sublingual space infection is there, you won't see the swelling outside. When you inspect the oral cavity, you're going to see the raised floor of the mouth and the tongue that is touching the palate or that is getting protruded out. This is the sublingual space infection. Whereas in submandibular, because of the muscle attachment, all of the pressure is going to be pushed out. So you're going to see a swelling in the submandibular region. This is submandibular space infection. Now in cases of mandibular anterior teeth, कौन सी muscle है? Mentalis. So you can see lingually we have the mylohyoid muscle attachment, whereas labially we have the mentalis muscle attachment. Again the same thing. In cases of anterior teeth, periapical abscess, if the abscess reaches lingual cortex first, which is quite rare, but if the abscess reaches lingual cortex first, it is going to cause the sublingual space infection because this is above the attachment of the mylohyoid muscle. If this periapical abscess reaches the labial cortex, now depending on the attachment of this mentalis muscle, either it can be vestibular abscess or it can be submental space infection. Now this pus is going to be pushed between the mylohyoid muscle, it will be pushed between the mylohyoid muscle and the platysma muscle here. So this is submental space infection. And this is how it appears clinically, swelling in the submental region. Now we are going to talk about primary and secondary spaces. अभी तक जो मैंने बातें बताई, these were primary spaces. Involvement, the spaces that are involved directly after the periapical abscess. Those are the primary spaces. And from the primary spaces, the infection spreads and involves other spaces. Those are the secondary spaces. So, ऐसा एक आपको table मिलेगा, flow chart मिलेगा in your textbook. So, suppose there is mandibular periapical abscess. What are the spaces that are involved first? Mandibular posterior teeth से कौन से spaces पहले involve होंगी? Submandibular, sublingual, that was the lingual side. If the infection spreads to the lingual side, submandibular and sublingual space is involved. If the infection spreads to the buccal side in cases of mandibular and maxillary posterior teeth, vestibular or buccal space infection, right? So we have buccal space. Then I told you guys, mandibular anteriors में कौन सी space पहले involve होगी? Either it is sublingual or submental, right? In cases of maxillary periapical abscess, anterior teeth, which space is involved first? Canine space. And इसके बाद एक और space रहती है, molars में एक exception मैंने बताया था, infratemporal space infection. So these are the primary spaces. Easy? Then from this, the infection from space, suppose buccal space, the infection can go to the submesenteric space. Submesenteric space is the space between the masseter muscle and the lateral surface of the ramus. Okay? यहाँ पे buccal space है, उसके just posteriorly we have the submesenteric space. So from the buccal space, the infection can spread to the submesenteric space easily. And submesenteric space में ही, at the posterior aspect, we have the parotid gland, right? Parotid gland is surrounded by the parotid capsule. So this infection can easily breach the parotid capsule and involve that space also. So from the buccal space, infection can spread to the submesenteric space, and from there to the parotid space. That is the parotid capsule. Okay. So these are the two secondary spaces after the buccal space infection. And from infratemporal, we can see there is the involvement of lateral pharyngeal and retropharyngeal. These are in the neck region. And from submandibular, sublingual, we can see the spread of infection to the pterygomandibular space infection. Pterygomandibular space is the space between the medial surface of the ramus and the medial pterygoid muscle. ठीक है, जहाँ पे हम inferior alveolar nerve block देते हैं. Okay, it is just posterior to the sublingual and submandibular spaces. So यहाँ से spread होके it can reach the pterygomandibular space, and from there the spread can go to the lateral and retropharyngeal space or to the deep temporal space. And finally, from the pharyngeal spaces, it can spread to the mediastinum, and then it can reach to the heart. So these were the secondary spaces: parotid space, submesenteric space, deep temporal, pterygomandibular space, lateral and retropharyngeal, and mediastinum. As we allow the disease to progress without any treatment, we are going to see combination of all the spaces, multiple spaces. For example, there is something called as Ludwig's angina. So Ludwig's angina में क्या क्या spaces होती हैं बताओ? Submental, that is only one. Sublingual and submandibular is bilateral. So we are seeing the combination of the spaces. So bilateral, submandibular and sublingual, one submental. So this is Ludwig's angina. This is just an example. And another thing, in some rare cases, I have seen pterygomandibular space can be a primary space also. Suppose we have a third molar impacted, horizontal है. So the root is in the ramus region. Because of the caries, there is periapical abscess in the root, that is in the ramus. Ab ramus mein, if the lingual cortex is breached first, the space present there is the pterygomandibular space. So it is quite rare, but it is seen in some cases. So this was Ludwig's angina. Now, what are the signs and symptoms that we can see in space infection in general? कोई भी space हो, these are going to be common signs and symptoms. So, अगर आपको ये lecture थोड़ा बहुत समझ आ गया, you can write about any space infection, at least half marks मिल जाएंगे, ऐसा है. So, signs and symptoms. So, any space infection, it is infection, and infection leads to inflammation, right? So, inflammation हो रहा है तो उसके कुछ signs and symptoms होते हैं inflammation के. What are those? Rubor, tumor, calor, and dolor. So rubor is redness and tumor is the swelling. So if you see this, in this case, you can see right submandibular space infection, there is redness and there is swelling of the face. So rubor and tumor is there. Calor is increase in localized temperature. And in some cases, जहाँ पे infection ज़्यादा spread हुआ है, we might see generalized increase in body temperature, that is also called as fever. So you might see calor, that is localized increase in temperature, or generalized increase in temperature, that is fever. Okay. Now this is increasing the temperature of the body is the body's protective mechanism. जब भी there is infection, the body tries to raise the temperature of the body and tries to kill off the microorganisms. So this is the protective mechanism. And then finally, of course, infection hai, inflammation hai, there is going to be some pain. So rubor, tumor, calor, dolor. Then finally fever जो मैंने बताया. Okay. Now, depending on the space involved, we will see different signs and symptoms. I'll just give you a few examples. If lateral pharyngeal space is involved or pterygomandibular space is involved, because of the swelling in the neck region, ये बाहर swelling नहीं दिखेगी, neck region में swelling है. So because of that, there will be dysphagia, dysphonia. Patient खा नहीं पाएगा, पी नहीं पाएगा, बोल नहीं पाएगा सही से, है ना? And suppose we have the submesenteric space infection or pterygomandibular space infection or deep temporal space infection. These are all infections involving the muscles of mastication. यहाँ पे submesenteric में we have the muscles of mastication, that is the masseter muscle. Pterygomandibular space में we have the medial pterygoid muscle. Deep temporal में we have the temporalis muscle. So these muscles, because of the infection, they go into the spasm, and they go into spasm, they lead to trismus, right? So you might see trismus also. So depending on the space involved, you will see signs and symptoms. Okay, so now we're going to talk about cellulitis versus abscess. What is a cellulitis? What is an abscess? By definition, cellulitis, it is an acute and rapidly progressing infection of the loose connective tissue that is present between the two layers of fascia. And in a cellulitis, जैसा मैंने पहले बताया, there is little, almost zero pus formation. It is more of inflammation and gaseous production, okay, gaseous content. So because of this, you don't have a clear demarcation. Because of inflammation and gaseous production, there is no clear well-defined borders. Whereas in abscess, it is just a simple cavity space filled with pus. So it is going to have a well-defined borders. So how do we see this clinically, the abscess and cellulitis? This is cellulitis. Can you see any proper demarcation kahan pe cellulitis khatam ho raha hai? No. So this is cellulitis with diffuse borders, whereas in abscess you can clearly see, okay, this is the border of the abscess. So this is how we can differentiate between the cellulitis and abscess. Again, we're going to talk about this in details. What are the radiographs that we take in cases of space infection? The most commonly used is orthopentomogram, that is OPG, because most of the time we have trismus. So anyways, IOPL le nahi payenge. So OPG is a radiograph of choice. Then you can use a CECT, that is contrast enhanced CT scan, to see the spread of the infection, one. Then second, to differentiate between a cellulitis and an abscess. Let me show you the image. Here you can see a CECT, contrast enhanced CT. In this you can see this is the cellulitis. There is no well-defined border. Whereas in abscess, can you see a clearly defined border? You can use CECT to see the spread of infection. One, second, to differentiate between the cellulitis and abscess. And how do we manage it? First is airway management. We have to make sure whether the patient is breathing properly or not. If the patient has difficulty in breathing, we can go for endotracheal intubation. But in cases where we see the infection in the neck region, that is lateral retropharyngeal space infection or pterygomandibular space infection, there is a possibility because of this infection and inflammation. The mucosa in the neck region, it is very weak. Okay, easily वो tear हो जाएगा आप जब tube intubate करोगे. There is a possibility of breaching that space, and वो pus जितना भी होगा, it will drain into the throat region, neck region. Okay, and the patient might aspirate that pus, and the patient can die. In those cases, we can go for tracheostomy. So, in such cases, you have to be very careful. If the patient is not able to breathe, you can go for endotracheal intubation. But you see, there is a lot of inflammation, and the mucosa seem to be very weak. Then you can go for tracheostomy. That is one, maintain airway. Second, early antibiotic. One of the principles of antibiotic is that you should use an antibiotic with the narrowest spectrum. But for that, we'll have to collect the pus or fluid, whatever comes out from the infection. And we have to send it for culture sensitivity test. And by the time we get the results from the culture sensitivity test, by the time we get to find out कौन से microorganisms infection है, we're going to start with the empirical therapy. Empirical therapy antibiotics is where we try to cover all the causative organisms that are possible in the head and neck region. So broad spectrum. And the most commonly and widely used empirical antibiotic therapy is amoxicillin plus clavulanic acid plus metronidazole. If the patient is allergic to amoxicillin, you can go for ceftriaxone plus metronidazole. As soon as we receive the reports from the culture sensitivity test, we are going to shift the patient to a narrow spectrum antibiotic with the most effectiveness to that microorganism. So then next is, as soon as we have the antibiotic start कर दिया, and we have to perform the surgical intervention as soon as possible. ऐसा नहीं है कि culture sensitivity के लिए भेजा है and we have to wait for the results. No, you start with the empirical antibiotic therapy, and you go and do the surgical intervention, that is the incision and drainage. Incision and drainage में क्या है? If you remember Hilton's method, most fluctuant and dependent area में हम stab incision देते हैं. But head and neck region में we don't give a stab incision पूरा ऐसे, because we have a lot of vital structures in and around the face. What are the two vital structures that are present in this region? Facial artery, one. Second, marginal mandibular nerve. किसकी branch होती है marginal mandibular? Facial nerve. So this is the case of left submandibular space infection, secondary to the caries in 3-7. So in this case, we did the drainage from the submandibular region. Whenever we want to give an incision, we're going to give incision at least 1 centimeter below the inferior border of the mandible. because from the studies we have found out that maximum level of the marginal mandibular nerve, the most inferior position is 1 centimeter. उससे नीचे हम रखेंगे तो we are sure that we are not going to damage the marginal mandibular nerve. So we are going to give an incision, then using a sinus forceps. What is the muscle here? Platysma. You are going to breach the platysma muscle. Platysma muscle and fascia के ऊपर we have the submandibular space, right? So we are going to breach the 2 layers, that is the platysma and the fascia, and then we are going to reach the submandibular space. And once we reach the space, we open the forceps. As we open the forceps, the pus starts coming out. We have to break all of those loci to make sure all the pus is removed from that region. Now, ये तो पहला step था, that we remove the pus how much जितना भी possible. Now, if this closes and there is more pus formation, it won't come out. So for that, we're going to place a drain, corrugated rubber drain. I'm going to show you the pictures of the drain. So it is a zigzag pattern like this, and we place it in the space. Okay, so it keeps the space open. We suture it to the skin to keep it in position. Now that is one. So this is the incision and drainage, and this is the corrugated rubber drain. Nowadays, this is the one that is used most, and this is made of silicone. The whole sheet, corrugated rubber drain sheet, is made of silicone, but we have this green line in every drain. This green line is radio opaque in case while placing the drain and this drain is pushed inside the soft tissue. And now we are not able to locate the drain. So क्या करेंगे? Because of this radio opaque line in the drain, you can easily locate it on a radiograph. So after you have placed the drain, we're going to cover it with a gumji pad. Gumji pad is nothing, just a cotton covered by a gauze, cotton gauze. So इसको भी gumji pad तो हम tightly दबा के नहीं रखते, we just keep it there in position. So that जो भी pus discharge हो रहा है, it gets collected in the gumji pad. So it is loosely placed over the drain. And another importance is it collects the whatever drainage is there. So we can see the gumji pad and we can see how much collection is there. So and this gumji pad is changed every 24 hours usually. But if there is more discharge, overnight रख के भी वो पूरा drenched है with the pus, then you're going to change it within 12 hours also. So this is gumji pad. So we are done with the early surgical intervention. Then after that, we're going to address the etiology. If we don't address the causative reason, that is the etiology, that is caries tooth in my previous case, this. In this, we have a caries 3-7, right? If we don't treat this tooth, be it root canal treatment or extraction, we have to address this issue first, okay? अगर ये address हमने नहीं किया, then causative reason तो वहाँ पे है already. थोड़े दिन तक swelling कम हो जाएगी. Once we stop the antibiotic, the swelling starts again. The infection starts again. So, causative reason जो etiology जो है, you have to address that also for a complete resolution of the condition. So, address the etiology and proper fluid intake. So, of course, because of the patient's condition, many of the patients, they have dysphagia also. The patient is not able to drink water properly, take fluids properly. So, patient might have dehydration. Then you'll have to give IV fluids. That is, preferred fluids are normal saline or ringer lactate. Okay. And if the patient is able to drink properly, then you can give 3.5 to 4 liters daily. So, these are the steps in management of the space infection. That is airway maintenance, early antibiotics, early surgical intervention, that is IND, and we have to address the etiology. If the caries tooth is there and you think you can save the tooth with root canal treatment, then you go for root canal treatment. If you think the tooth cannot be saved by root canal treatment, extract the tooth, okay? If there is an etiology of infected implant, dental implant, take the implant out. And the last thing, hot fermentation. In case of space infection or cellulitis, because of the pressure from the swelling and the gaseous content, there is occlusion of the arteries also. Okay? So blood supply, oxygen supply, antibiotic supply to the site is reduced. So once you have reduced the pressure, basically incision and drainage करने का aim यही होता है कि we are reducing the pressure, and in case of abscess we are removing the content, that is the pus. So once you've done the IND, we can ask the patient to do hot fermentation after 24 hours of the procedure. Okay? उससे क्या होगा? The swelling that is there, the hard swelling in cellulitis, it softens up one,
Second, because of the hot fermentation, there is dilation of the capillaries, the blood vessels. So blood supply is increased to the site. So we can ask the patient to do hot fermentation also. So this was your space infection basic lecture.